Uh, Good morning or afternoon. Uh, I'm Dr. Ron Kirshner, physician toxicologist at the Nebraska Poison Center. We're going to talk about acetaminophen overdose. And we'll talk about when and when not to apply the Nomogram, recognizing patients who are most at risk of serious toxicity and treatment options. Let's start with the case. This 29-year-old man presented to a community hospital ED with GI complaints. They did labs and noticed that, his ALT and AST were both greater than 1,000. They got some additional history and realized that he was probably misusing an acetaminophen product. So got a level, and it was barely detectable, so they started him on oral acetylcysteine. We'll come back to him. This is a case we heard about by phone. A gentleman ingested a large amount of acetaminophen. He had a 4-hour level that was impressive, over 1,000 micrograms per ml. Apparently no co-ingestants. He became lethargic and developed an anion gap acidosis with a pH around 7, a high lactate. His liver enzymes remained normal, but he had a mildly elevated INR. And because of his CNS depression, he was intubated, antidotal treatment was started, and he was transferred to a liver transplant center. We'll come back to him. So acetyl para-aminophenol is abbreviated APAP. In the US, it's acetaminophen. In the UK, it's paracetamol. It's our most common pharmaceutical overdose, very safe at therapeutic dosing. But in the US, it's #1 cause of liver failure. So it's rapidly absorbed. It's got a short half-life, at least therapeutic dosing. And how does it hurt the liver? Well, trick question, because it's really not the acetaminophen or its major metabolites that hurt the liver. It's a minor metabolite that nobody can really pronounce or spell very easily. So we call it by its initials, NAPQI. That's fairly unstable. So it reacts with the nearest electron pair that it can get a hold of, usually cysteine residues on hepatic proteins, setting in motion a cascade of inflammatory events causing hepatic cell damage and death eventually. These are the major pathways which produce non-toxic metabolites. In that minor pathway, which accounts for less than 5% of the acetaminophen, through the cytochrome P450 enzyme 2E1. Normally, that toxic metabolite is detoxified by something called glutathione, a tripeptide that's abundant in the healthy liver. So normally, at therapeutic dosing, it's not a problem. People have plenty of glutathione, and you never notice it. But in an overdose situation, the glutathione stores can be overwhelmed, and the pathways accounting for the major metabolites can be overwhelmed, so you produce more of the toxic metabolite. So you normally have a window because of the glutathione stores, and you normally have about 8 hours before you start running into trouble. So if you go beyond that, then you risk getting into more serious liver injury. So how do people present? After an acute overdose, they often have very minimal symptoms. They might have some nonspecific GI upset. You'll see elevations in their liver enzymes, but that often takes some time. It often takes 18, 24 hours, occasionally longer. The AST and ALT start to bump up. They usually go up about the same rate. Occasionally, in patients who are sicker because of a very large overdose, the AST might rise more quickly. Now, if they do have liver injury, it peaks later. Once the liver injury process is started, the peak is typically not till 72 to 96 hours out. And then the patient usually recovers. Once they're in that recovery phase, the AST typically declines, improves faster. Now, because this liver injury is delayed, this is a laboratory diagnosis. So we said it's our most common pharmaceutical overdose. So we have somebody that we suspect this is an overdose patient. We generally recommend acetaminophen level on every suspected overdose patient. We're not going to be able to recognize, oh yeah, we can, predict acetaminophen overdose based on the symptoms, because there really aren't any. So even if the patient doesn't think they took Tylenol, well, acetaminophen is present in hundreds of different products. What about outside the liver? Some patients are going to get kidney injury. Is that because the toxic metabolite circulates around and goes to the kidney? No, it's very reactive. It doesn't last that long, but they also have some CYP enzymes in the kidney and make the toxic metabolite there. So a reasonable percentage of patients with serious liver injury will get kidney injury, but that's also going to be delayed. What about more systemic effects? Patients with very large acetaminophen overdose, typically with levels in the hundreds, may have what's sometimes called mitochondrial stunning. These very large overdoses can affect energy production in the mitochondria. And they may have metabolic acidosis with high lactates. They may have CNS depression, hypotension, and these more systemic effects. So how do we decide who is going to be at risk? As we said, you could just observe every acetaminophen overdose to see if they're going to get liver injury. But back in the 1970s, the Nomogram was developed in the UK. So the Nomogram is a way of predicting based on the acetaminophen level and the time of ingestion, who is going to develop serious liver injury after an acute overdose. But it really just applies to those people with an acute overdose at a specific time where they took it all at once. So a lot of people are just not going to be candidates for the Nomogram. People who are repeatedly taking excessive acetaminophen for pain, the staggered overdose patients where they're spreading it out over the course of the afternoon, or the people with altered mental status who've got an unknown ingestion time. And this was developed empirically, where the Nomogram was developed to separate those patients who developed what they defined as serious liver injury from those patients who didn't develop serious liver injury. What did they mean by that? They defined serious liver injury or hepatotoxicity as who gets ALT or AST greater than 1,000. And so it went through various formulations. You might see something that looks like this with two diagonal lines. So the higher one was the original Nomogram line that started at the 200 micrograms per ml at 4 hours, and then it declined gradually. The one that was the original one in the UK. The one that was adopted in the US was lowered by the FDA as an extra safety margin. That's the one that we still use today, and it's used in other countries. It's used in much of Canada, Australia, and other places. It starts at 150 mics per ml, at 4 hours. Why 4 hours? The idea was by then you've absorbed most of your drug, and then it declines. So what is the threshold decline? Well, that's just the way that it worked out. When they did this empirically to see what happened to people who actually developed hepatotoxicity. So the half-life of the nomogram line, and I use the half-life in air quotes, is 4 hours. It's not based on the pharmacokinetic half-life of acetaminophen. It's just the way it worked out with the actual patients that they derived it from. So what does that mean? The threshold based on the nomogram is 150 at 4 hours, it's 75 at 8 hours, it's 37.5 at 12 hours. And you can see where I'm going with this. As you get further and further out from the ingestion time, it's just, it's not that useful. When you get out to 20 hours, the threshold is 9.4. And that would actually be below the limit of detection at a lot of labs, including the one at our parent institution, where the limit of detection is 10. So it's not that useful when you get out to 20 hours. In fact, when you get out that far, you're more interested in this green curve, which is your AST and your ALT, your liver enzymes. The red curve, the acetaminophen concentration, is often non-detectable by that time. So another confounding factor is more so than the 1970s, we see a lot more combination products. So what do these two combination products have in common, besides the fact they both contain acetaminophen? Well, one contains an opioid, hydrocodone, the other contains an antihistamine, diphenhydramine. So these are both things that slow GI motility. And somebody overdoses on one of these things, they may be a line crosser. So somebody overdoses on Tylenol PM. They might have a 4-hour acetaminophen of 120. It's below 150, so it's a little below the treatment threshold. So what happens? You could say, all right, that person doesn't need treatment. But because of the altered GI motility, that person might have an 8-hour level that is 110, a little bit less, but that is now above the threshold, which would be 75 at 8 hours. So we recommend with these combination products, it's often a good idea to get a second level. What about the repeated supratherapeutic ingestion? So people are taking excessive acetaminophen product to treat their musculoskeletal pain, to treat their COVID, or whatever. So the nomogram was not designed to deal with that kind of situation. Nomogram is for a one-time ingestion at a known time. So we still get a level to see, was this really an acetaminophen ingestion? Do they still have acetaminophen in their system so that they're still making the toxic metabolite? And we want to see what are their liver enzymes like. So we still do the labs. We don't do the nomogram. We treat them empirically if they still have a significant acetaminophen or if they have elevated liver enzymes. Now, there's another diagnostic prognostic tool that we can use, something called the multiplication product. And this is really intended more for prognosis than to decide whether or not to treat them. And this can be very helpful. It's basically taking the acetaminophen level in micrograms per ml and multiplying it by whichever enzyme is higher, the ALT or the AST. And this has been around for about 11 years. There's a lot of experience. There's quite a bit of literature on it. So we know from the experience of studies on thousands of patients This is predicting what is the risk of hepatotoxicity. What's the risk that patient is going to get liver enzymes greater than 1,000? Now, of course, if they present and their AST or ALT are already 1,000, you don't use it because you already know that answer. What if their acetaminophen is less than 10? Well, then how do we do the calculation? We use a value of 5. We assume the acetaminophen is somewhere between 0 and 10. We call it 5, so we can actually do a calculation. And so we know if the multiplication product is less than 1,500, their risk of hepatotoxicity / serious liver injury is extremely low, on the order of 1%. But if it's more than 10,000, they've got high risk. So yes, you could treat them empirically, but if the multiplication product is less than 1,500, you could probably be justified in just observing them. What do we do with the acute overdose patient? We give them charcoal in the first 1 to 2 hours. That's the usual teaching, but there's some studies out of Australia that if they have a massive overdose, and what do we mean by that? Some people define that as more than 30 grams by history, or an acetaminophen, a serum level greater than 300. Those folks may benefit from charcoal up to 4 hours post-ingestion. We check their liver enzymes, we check their INR, lactate, in addition to treating them with the antidote, which I'll get to. One caveat I'll mention: if you check their INR, supratherapeutic acetaminophen will have a direct effect on the clotting factors. So even if they don't have liver injury, someone with acetaminophen in the 300 range, they're going to have an elevated INR just from the acetaminophen, even if their liver enzymes are completely normal. So why are we checking the liver enzymes in somebody who's only 3 or 4 hours out from their ingestion? Well, it's just a check, because we know for various reasons in intentional overdose patients, the histories may not be completely reliable. So it's a way of screening. If we find those liver enzymes are elevated, that's a clue that the history may be incomplete or maybe inaccurate, and we're going to treat them based on the labs. We're going to trust the labs, and we're going to treat them. So who are the really high-risk patients? Number one are the late presenting patients. For whatever reason, if they present the next day, that person is much higher risk, because that inflammatory process set in motion by reaction of the reactive metabolites with liver proteins, that's been going on for a while. They're at much higher risk for serious liver injury. Repeated supratherapeutic ingestions, they're also at high risk. And of course, the massive ingestions. What do they have in common? They've all depleted their liver stores of glutathione. That's the thing that's protecting them. The glutathione that detoxifies the toxic metabolite. And of course, the late presenting patients, they're presenting long after they've depleted those stores. So they get started, typically early, before you even get back their acetaminophen level. If you know that they're presenting 12, 15, 18 hours out. Now, other things can elevate your liver enzymes. Rhabdomyolysis. Patient has been lying on the ground for many hours. They've been having multiple seizures or extreme agitation. What's the clue to that? Their AST is much higher, 3 to 4 times the ALT. Then I would check a CK. Maybe they've got rhabdo. ischemic hypoxic injury to the liver. Maybe they were hypotensive, they weren't perfusing their liver. That can look like an acetaminophen overdose. So you may have somebody who has a negative acetaminophen, but they have elevated liver enzymes. That can be somebody who had a recent acetaminophen overdose, but the acetaminophen is already cleared. That person probably should be started on acetylcysteine, on treatment. Of course, it could be some other drug, but acetaminophen is by far the most common. If it's unclear, acetylcysteine, the treatment is relatively benign. Alcohol use disorder, that's a possibility, but the AST is only going to be so high, typically up to about 300, and it's usually going to be about 2 to 2.5 times the ALT. So if it doesn't fit that pattern, I'd be hesitant to attribute it to that. So this is our treatment, and the primary, this is N-acetylcysteine or acetylcysteine. The primary role is to detoxify the toxic metabolite. So cysteine is one of the 3 amino acids in glutathione. So it can substitute for glutathione, or it can act as a precursor to form more glutathione. So the primary mechanism is detoxify the toxic metabolite if you still have acetaminophen and you're still forming toxic metabolite. But the question comes up, what if you've already cleared the acetaminophen and you still have serious liver injury, but no more acetaminophen left? Can it help those patients? The answer is it can. From some studies in the UK in the 1990s, patients who developed liver failure from acetaminophen, but had cleared the acetaminophen, those patients still had improved mortality when the acetylcysteine was continued. So on the basis of those studies, we continue to treat those patients. It can be given orally or IV. They both work, never compared head to head. But the IV stuff is much easier to give in a critically ill patient, obviously somebody who can't take a PO or has an altered mental status. So patients who present with really high acetaminophen concentrations, they may need more than the standard dosing. It's somewhat controversial where that cutoff is. But if you live in Australia and you present with an acetaminophen concentration more than 300, which is more than double the threshold at 4 hours, you're going to get double the IV infusion rate at maintenance. And you may need even more than that if you present with a super high, let's say you present with an acetaminophen concentration of 600 with a serum acetaminophen. So it's not very common, but I did provide some references for that. So people occasionally do that. And there's some debate as to where those cutoffs are. Is there any adverse reaction to acetylcysteine? Well, if it's given orally, it's usually nausea and vomiting. If it's given intravenously, they can get anaphylactoid reactions. They're not immunologically mediated, but they are mediated by histamine. And they can look a lot like an allergic reaction. Most of them are cutaneous with flushing, urticaria, pruritus, and most of them are relatively easy to deal with. Stopping the infusion, giving them antihistamines. And when do they occur? They occur after the loading dose, when they've gotten a very high rate of infusion, after they get that loading dose at the very beginning of our 21-hour protocol when they've gotten half of that 300 milligrams per kilogram right off, right in that first hour. So they usually tolerate the rest of it after they get their antihistamines. Most of the time, that is not a problem. Now, there are other regimens. There's a 2-bag regimen in the US that is done at a few places. And in the UK, where the 21-hour protocol was developed, they don't even use it anymore. They now use something called the Scottish and Newcastle antiemetic pre-treatment for paracetamol poisoning, something known as the SNAP protocol, where they start off giving the acetylcysteine more slowly and then ramping up the infusion rate. And they find that it reduces the incidence of adverse reactions. They also complete the infusion faster. But it just hasn't, for some reason, it hasn't caught on in the US. And I think if you ask most non-toxicology physicians in the US about SNAP, they'll probably think you're talking about food stamps. But they've had very good results with it in the UK, and I think at some point it'll probably come over here. So in terms of lab monitoring, patients who have more serious liver injury, hepatotoxicity, liver enzymes greater than 1,000, we worry that they're going to go on to liver failure. They're going to go on to develop coagulopathy and encephalopathy. So they need to have monitoring of their liver enzymes and their INR. And this needs to be done at least every 12 hours, typically in an ICU type setting. And those patients should have some sort of consultation with a liver transplant center. They might not be liver transplant candidates because of ongoing substance abuse or repeated self-harm attempts or something like that. But often the transplant center will take them anyway, just because they have more experience treating liver failure patients. That happens all the time at our parent institution. As far as prognosis, what's important in that? It's not the numeric value of the liver enzymes. What's important are indicators of function. The level of INR, the mental status, their acid-base status. So what are known as the King's College criteria. And of course, these days, you're not going to memorize them. You would just look them up on your smartphone. So the King's College criteria, though, are not going to be set in stone. They're going to evolve over time. So these are going to determine, are they going to survive without a transplant? And if they meet the King's College criteria, their survival without a transplant is going to be on the order of 10 to 15%. Yes, it's possible, but not that likely. So other issues include these sicker patients. If they still have a very high acetaminophen level, do they need a higher infusion rate? Now, the higher infusion rate is only if they have a high acetaminophen concentration. If they just have very elevated liver enzymes, they don't need a higher infusion rate. They can just have the plain regular infusion rate. If they have a really high acetaminophen concentration with severe acidosis and high lactate, the so-called mitochondrial sunning, they may even benefit from hemodialysis because acetaminophen can be removed by dialysis. Of course, it'll remove the acetylcysteine too. So if they're getting that, that should be given at double the normal infusion rate. So what happened to our cases? The gentleman who presented with GI complaints. Well, he had liver enzymes that were a little over 1,000 by the second day after he got transferred to a parent institution. They were in the 10,000 range. And as you can see, he met the King's College criteria. He had acidemia, he had kidney failure, and he had severe coagulopathy. He was still alert initially, but then he became encephalopathic. And he got very lucky, though, and they found him a liver. The second case with 4-hour acetaminophen greater than 1,000. So he was a phone consult, not in our catchment area immediately. He was in a distant area. He was transferred to an out-of-state transplant center. He was treated with acetylcysteine. At the transplant center, he got dialysis because his acetaminophen concentration was close to 7 times the Nomogram threshold. And actually, his ALT and AST remained within normal range. He basically had the mitochondrial stunning, and he did okay. So prevention is key. Patients have to be educated on what's in their medications and make sure they're not double dipping, make sure they're not combining different acetaminophen products, such as plain acetaminophen and some of the combination products with opioids or antihistamines. And if they're early presenters with a known time of ingestion, you've typically got time to get a level, see where you're at, and use the Nomogram. If they're late presenters, you're behind the 8 ball. If they're 12, 15 hours out, then it makes more sense to start the treatment while the labs are pending. And if they present with elevated liver enzymes and a non-detectable acetaminophen, this may be a recent acetaminophen overdose. It's reasonable to treat those people until you sort it out and see, are the liver enzymes going up or down? You won't know until you get more than one level. Typically, we'll repeat that in 12 hours or so. And we'll continue the liver enzymes, we'll continue the treatment until we get that next set. If they're getting treated for serious liver injury, then we care about the King's College criteria. We care about the coagulopathy, mental status, and the kidney function. Those are my references. And if you get a chance, please visit our website and try to fill out a brief evaluation at our websites. We really appreciate your input. So thank you for listening, and have a great day. And don't forget to call us when you have a possible overdose patient. Thank you again.